Hello, friends. Uh, the topic for discussion is hysteroscopic markers of genital tuberculosis. And I'm Dr. Chaitanya Shembekar. I bring greetings from Omega Hospitals, Nagpur. My special thanks to POGS for giving me this opportunity. I am thankful to Dr. Sunita Tandurkar, who will soon become our national leader, Dr. Nilesh Balkaude, and Dr. Chaitanya Ganpure for giving me this opportunity. As we know, genital tuberculosis is a major cause of infertility in developing countries, especially in India. It is mostly a secondary manifestation where the primary is always in the lungs. Genital tract is vulnerable to infections during puberty, and most of the cases they happen during puberty. So what happens that whenever there is a primary lesion in the lungs, it heals and a lesion is dormant in the genital tract which gets reactivated later in life. The manifestation of genital tuberculosis, as we all know, is either infertility or lower abdominal pain. So pain and infertility are the two serious consequences of genital tuberculosis, and the patient may have impact on the treatment of IVF as well. The other day, I was listening to this song, Love is in the Air, by John Paul Young, while I was preparing this presentation. And the thought which came to my mind was in India, TB is in the air. Wherever I look around, TB is in the air, every sight and every sound. And I know I am not foolish. It is the truth. TB is in the air. So we have to accept this fact that tuberculosis is so rampant in India that it is in the air. And you have to think of tuberculosis in any situation wherever there is a problem. Tuberculosis should always be in your mind, and you should keep high index of suspicion while treating the patients with infertility, keeping tuberculosis in mind. Now, as far as the assessment of endometrium is concerned, we have many options. The three most popular options are HSG, transvaginal sonography, and hysteroscopy. HSG is nowadays taking a backseat, while 3D transvaginal sonography is becoming more and more popular. However, still there is a role of hysteroscopy for diagnosis of tuberculosis, और कोई माइका लाल इस हिस्टोस्कोपी के पोजीशन को हिला नहीं सकता. If you just look at the guidelines, there is some controversy about the role of hysteroscopy in the diagnosis and in infertility. But all the guidelines, they say that whenever you are suspecting any pathology, there is always a role of hysteroscopy. So in genital tuberculosis, if you are suspecting tuberculosis, you should always think of hysteroscopy as the first and the gold standard for the diagnosis of tuberculosis. So hysteroscopy का रोल बेशक बहुत ज़्यादा है. It not only helps in the diagnosis but also helps in the treatment. So it is like see and treat policy. You see the problem and you treat the problem in the same sitting. Whether you should do hysteroscopy along with laparoscopy or not is the question. It depends on the situation. But here you can see this is a very classical appearance of genital tuberculosis on laparoscopy, where you can see the tubercles, you can see the adhesions, you can see hydrosalpinx, and in this case you may have to do the delinking as well. So in this situation, laparoscopy definitely has a role to play along with hysteroscopy. But in some situations, you may have to do only hysteroscopy. And in this case, whether to do regular hysteroscopy or office hysteroscopy depends on the situation. But nowadays, the trend is towards office hysteroscopy, and hysteroscopy, if done in the office procedure, is something which is accepted by many people in India as well. What is the best time of doing hysteroscopy? It is said that during initial stages, premenstrual hysteroscopy is better because there are white flecks, which is a classical feature of tuberculosis. These flecks may disappear after menses. Therefore, if you do hysteroscopy before menstruation, you get good findings which can help you in the diagnosis of hysteroscopy, like hyperemia, irregular surface, and white flecks on hysteroscopy. The classical appearance of hysteroscopic findings of genital tuberculosis are rough surface, dirty picture seen on hysteroscopy as seen in this picture, pale endometrium, the gland openings are not seen, overlying whitish deposits are seen. You can see these whitish deposits on the endometrium and adhesions inside the cavity. Now, do we get all these signs? No, we may not get all this science, and therefore you have to be very careful. It is said that the eyes see what the mind knows, and therefore be very careful while evaluating each marker of genital tuberculosis in histoscopy. The first thing which is classical of endometriosis and tuberculosis and in endometrium is the solitary tubercles and white deposits. These large white deposits are often seen and they are seen inside the cavity anywhere. The location of these tubercles may vary. Most common site is inside the cavity, and if you do proper magnification, you will be able to visualize these white spots very clearly. Then, as the disease advances, along with the white spots, you start getting the scarring and the adhesions. And this scarring is seen all over the endometrium and also seen in the endocervical canal. So, the two things which are appearing now is the white tubercles and the scarring or the fibrosis. The scarring has got a very classical picture. Initially, this scarring is flimsy. So the adhesions are flimsy, and white deposits they also appear early, and the adhesions which develop are flimsy. If you just try to break these adhesions with the help of hysteroscope, you can easily break these adhesions. And as I have told you, the white deposits they shade off during menstruation, and therefore premenstrual hysteroscopy is better in the initial phases. But what happens as the adhesions they develop, the white spots or the tubercles they cling, they get attached to this flimsy adhesions, and therefore even if you do hysteroscopy in the post-menstrual phase, these white spots they do not shed off, they still remain attached to this flimsy adhesions, and you can clearly see the white spots along with the adhesions. So that is step number 2. As the disease advances, initially you get only white spots, after that you get flimsy adhesions, and then these adhesions they become dense, and with the flimsy adhesions you will be able to get the white deposits which are adherent or attached to these flimsy adhesions, and therefore they remain attached, and even in postmenstrual phase you will be able to diagnose this condition. It is said that never say die, jit aise na chodo. If you have a high index of suspicion about tuberculosis, you should always keep that tuberculosis you will be able to see sometime or the other whenever you are doing hysteroscopy. So what you do is if you don't find tubercles, you just put the methylene blue dye. This methylene blue dye which is used for chromoperturbation, it will help in actually finding the tubercles which are seen like glistening white, highly reflective deposits which are observed against the deposit of the dark blue stained endometrium. It is called as starry sky appearance. So as you can see here, these are the deposits which become very clear and they reflect against the dark blue surrounding. And this is something which is classical of tuberculosis, which is called as starry sky appearance. So here you can see this video where you can see the tubercles, you can see the cavity which has got white flakes, and if you put the methylene blue dye in this situation, as you can see here, the methylene blue dye gives you a starry sky appearance, and these white spots can be seen which are glistening, a classical tuberculosis feature, and this feature is diagnostic of tuberculosis. So you put the methylene blue dye and you get this picture, and this picture is suggestive of genital tuberculosis. Very nicely seen in this hysteroscopic view. If the scarring is subtle, what you can do is you can just increase the magnification, and with increased magnification you will be able to see the subtle scarring as well, with the rough endometrium and sprinkled white powder like patches seen on the rough endometrium with bumpy surface is suggestive of tuberculosis. So this is a classical picture where you can see small tubercles. We have to follow some rules while you are doing hysteroscopy. You enter inside, and the first thing you see is the fundus. You may get scarring on the fundus and a fundal fibrosis. The fundal fibrosis is a feature of tuberculosis. Then you may get spotted endometrium on the fundus, which is again a classical feature of tuberculosis. Then you see the ostia, the right ostia, the left ostia. The ostia may be normal, but usually it is the ostium which is first affected by the tuberculosis, and therefore you get a very classical periosteal fibrosis with pinhole ostium. So this small pinhole ostium with periosteal fibrosis is the feature of tuberculosis. In this case, you may get tubal blockage, and you may have to do the cannulation. So you can see in this video, this is a classical pinhole ostium, and in this ostium you have to put the cannulation guide wire to do the cannulation if the tubal block is there. So along with laparoscopy, if you are doing hysteroscopy, and if you see this pinpoint ostium, that is suggestive of tuberculosis. Then initially, as this picture shows, you may get bands of adhesions with pinpoint ostium with scarring, but later on it becomes dirty. This is a classical dirty picture where there are adhesions, the endometrium is not seen, the ostium is not visualized. If it is visualized, there are deposits of endometrial flakes all around the ostium, and the ostium is really bad. And then you get this classical adhesion. So you can see here, as the disease grows, the fibrosis becomes dense, and you get the dense classical adhesions of tuberculosis. These adhesions, they take many forms. They may be seen in the form of bands, as you can see here, the classical fibrotic band, or you may get a fibrotic ridge, or you may get dense adhesions. So these are the steps where you initially find ridges and bands, and then you get dense adhesions and you cannot see the cavity at all. Now, whenever you are suspecting a case of genital tuberculosis, you have to keep in mind that when you enter inside, you have to be extremely careful, because this is the point where you may actually perforate the uterus because of the scarring, and there is a difficulty in dilatation of the endocervical canal. The cervix is difficult to dilate, and if you apply force or if you go in the wrong direction, the already scarred cavity may get perforated. So be very careful while doing the dilatation of the cervix. And as you enter inside, this is the picture which you may get. As you can see, these are the tubercles which are seen. You can see there are adhesions. The adhesions are very clear, dense, and the classical tubercles seen on these adhesions are diagnostic of genital tuberculosis. So if you get adhesions, you may have to do adhesiolysis. Whenever you are doing adhesiolysis, you have to be extremely careful, again, because the chances of perforation are more. Whenever you treat the patient of tuberculosis with AKT, you may think that whether the patient is responding to treatment or not. You have to check this. For this, you may have to do post-treatment relook hysteroscopy. This relook hysteroscopy is good because it gives you helps you in the diagnosis. You can see the healing which is apparent, the vascularity is increased, and there is an improvement in the mucosal morphology. So this is the classical feature. Now, I'll just tell you some features of chronic endometritis, because chronic endometritis and genital tuberculosis, many times they go hand in hand. The classical feature of chronic endometritis is strawberry appearance, where you see the prominent white glandular orifices surrounded by hyperemia. The stromal edema is there, and the endometrial thickening is there, and the classical feature is micropolyps. As you can see, this is the strawberry aspect, and these are the micropolyps which are seen, which are classical of chronic endometritis. These polyps are very small in size. They are actually of the size of some 2 to 9 millimeters, and they are very small in size, and they are not only small in size, but they are translucent as well. As you can see here, these polyps are translucent, and this is a feature of chronic endometritis, which is also seen in tuberculosis in some situations. There are many case studies, case reports, many studies regarding genital tuberculosis. This is the Brazilian study which has said that they found the cotton aspect. They have called this finding as cotton aspect, where they found white endometrium in genital tuberculosis. This is something which we very often see. This is called as cotton aspect, which can be suggestive of genital tuberculosis. And then there is one more study which has said that even the endometrial polyps can be a tubercular polyp. So this is the inflammatory structure which is arising from the posterior cavity, and there are some prominent gland openings which are seen surrounded by hyperemic halos, and this polyp can be a polyp of genital tuberculosis. So this you can see in this video clip, the small polyp which is in the cavity, and when we remove this polyp, by doing polypectomy, and when we send this for histopathology and other tests, we found that there was a genital case. This was a case of genital tuberculosis. So polyps can be tubercular as well, and something which you have to keep in mind, because you always feel that polyps are benign, they may be associated with infection and even genital tuberculosis. So what is the take home message? Take home message is very clear. Hysteroscopy is the gold standard for the diagnosis of genital tuberculosis. In some cases, hysterolaparoscopy may be done. In some cases, only hysteroscopy is sufficient. Whenever you are doing hysteroscopy, you have to follow the steps. First, see the fundus, then look for the ostia, then see the lateral walls, and finally, when you are coming out from the cavity, you see the cervix. That is how you follow the steps. The see and treat policy is going to help you, because if you find that there are adhesions, then you should be able to do the adhesive lysis in the same sitting. You should be extremely careful while doing dilatation, while entering inside, and while doing adhesive lysis as well. And you have to investigate this case further to confirm the diagnosis before starting treatment for genital tuberculosis. So, hysteroscopy is a very important investigation, and whenever it is done by a proper person, then you can do wonders. As you can see, you can do wonders, and sky is the limit. So what is required is hysteroscopy from a proper person at the right time. It can actually save the patient from chronic disease, and not only this, you can actually treat the patient, and infertility can be taken care of if you diagnose the genital tuberculosis at the right time. So early diagnosis is something which is important for the treatment of genital tuberculosis, which is so common in India. Thank you so much. Thank you for giving me this opportunity. And I would have loved to physically come to Pune and present my uh, study in front of the August gathering, but maybe next time. Thank you so much, Pune OBGY Society, for giving me this opportunity. Thank you.